Hi, everyone. Welcome to the cancer screening discussion today. Sorry, do I have ability to change? No. Perfect. So these are just some housekeeping suggestions. If you have questions, feel free to put them in the comment box or just raise your hand. This session is being recorded, so just so everyone's aware of that. If we can go to the next slide. The presenters' disclosures, there have been no financial disclosures of conflicts of interest with the presented materials today. If we go to the next slide. Okay, so we'll introduce, we have the two co-leads of the Durham OHT. Sorry, are they going to, I apologize, guys. I assume everybody knows them. Our presenters will be speaking. I'm Avnish Mehta. I'm the Regional Primary Care Lead, and I'll be doing the first part of the presentation. Go to the next slide. Okay, so I'm going to talk very briefly today, everybody, about the role of primary care screening. The role of primary care in cancer screening. If we go to the next slide. And so these are, so as everyone I'm sure here knows, primary care has an absolutely fundamental role in cancer screening. There's been many studies which have shown that when patients are recommended cancer screening by their primary care physician, they are much more likely to proceed with it. So if we go to the next slide, please. So the main cancer screening programs that we're going to talk about today, well, the cancer screening programs in Ontario we're going to talk about today are the colon cancer screening, the cervical cancer screening, the breast cancer screening, and the lung cancer screening. And I'm going to talk, my colleagues are going to talk about the first three, and I'm just going to go right into the lung cancer screening program. If we go to the next slide, please. So just a little bit about lung cancer. So lung cancer is the second most common diagnosed cancer in Ontario. It accounts for 13% of cancer diagnoses, but it is the #1 cause of cancer death in Ontario with 24% of the cancers. The 5-year survival for lung cancer in Ontario is about 20% now, and in the last 10 years there has not been a significant improvement in that. If we go to the next slide, please. So this just shows you the importance of lung cancer screening. So currently, and often unfortunately, lung cancer is diagnosed at an advanced stage with limited treatment options. So low-dose CT screening can detect lung cancer earlier when we're more likely to have successful treatment options. Next slide, please. So where's the evidence for lung cancer screening? Well, Cancer Care Ontario has taken most of its evidence initially from the National Lung Screening Trial, the NLST. So this was a randomized trial of over 50,000 participants. They were eligible for this trial if they were between the ages of 50 and 74, smoked at least a 30-pack year history of smoking. They were current smokers or former smokers who had quit in the last 15 years. So the gist of the trial is that it showed that people who are at high risk of lung cancer, who got screened annually for 3 years with low-dose CT, they had a 20% relative reduction in lung cancer mortality. And this was compared to people who got screened annually for 3 years with just a chest X-ray. And so the number needed to screen to prevent one cancer death from lung cancer was 320. If we go to the next slide, please. So Cancer Care Ontario recommends lung cancer screening should take place within an organized screening program. So low-dose CT should be the modality for lung cancer screening. Chest X-rays should not be used for screening high-risk populations. And the lung cancer screening program should have an embedded smoking cessation program. So why are they, next slide, please, sorry. So why are we suggesting a organized screening program as opposed to ad hoc or an opportunistic screening program? The reason is the opportunistic screening program has been shown in the past to have more diagnostic CTs, which have a much higher degree of radiation than the low-dose CT, and people had more incidental pulmonary nodules, which had follow-up scans, which were not always necessary. So an organized lung cancer screening program has been shown to have a greater protection against the harms of screening, possible harms of screening. They have mechanisms to ensure that CT scans are used appropriately with the low dose radiation. They're done without contrast. They're interpreted by radiologists who've received the training to read the low dose CTs. They use an algorithm for managing the patients with suspected nodules. And so this seems to minimize the risk of unnecessary follow-ups or scans. Next slide, please. So this is just an overview of the screening pathway. So the current screening pathway, the physician completes the referral form. A risk assessment is done by the screening navigator. And this screening navigator will then determine their eligibility for low-dose screening based on a risk prediction model, which I'll talk about a little later. At every point in this screening, in this pathway, if a patient is a current smoker, they're always offered a smoking cessation program, and if they want, they'll be referred into it. If they are determined to be eligible for low-dose CT, then they're referred to for a screening visit, where a more broader discussion is had with them of the risks and benefits of the screening. Again, smoking cessation offered if appropriate. And if they're agreeable, then they're referred for the low-dose CT. At every point in this pathway, communication is sent back to the referring physician. Next slide, please. So I think I've already talked about this, the potential benefits of lung cancer screening, detected at an earlier stage. And then there's smoking cessation programs, and there's a smooth transition to the diagnostic lung assessment program if that's necessary for the client. Next slide, please. So again, briefly on the harms of lung cancer screening, low-dose CT is more radiation than the chest X-ray, although it's 25% of that of a diagnostic CT. You can get false positives, which can lead to unnecessary assessments. You can also get overdiagnosis, which means picking up early lung cancers, which may never have been clinically relevant. That all being said, the algorithms are set up for who gets screening and who needs follow-up to try to minimize these potential harms. Again, another benefit of an organized screening program. Next slide, please. So who should not be in this program? Well, as we keep calling it a screening program for good reason, it's a screening program. So anyone who has any of the suspicious signs for lung cancer should not be part of this program. They should have the appropriate chest imaging. Next slide, please. What goes into the risk assessment? Well, the risk assessment looks at the patient's age, their smoking history, their current medical history, their personal history of cancer, family history of cancer, and they take that risk assessment to come up with, and if we'll just go to the next slide, come up with their 6-year risk of developing lung cancer. This 6-year risk of developing lung cancer, then, if it's greater than 2%, the risk model determines that they are eligible for the low-dose CT. Now, this model has been improved a little bit from the NLST study that I referenced earlier. So this is considered more efficient, and actually the number needed to screen currently based on this assessment is about 233 to prevent 1 lung cancer death. So how to refer? Well, any referring physician or nurse practitioner can refer into the program. We ask that if they have a primary care provider, you identify it if you're not that provider. The referring practitioner and the primary care provider will then be copied on all communications. When someone is referred into this program, they are now authorizing the low-dose CT for that patient if it's deemed appropriate, and for appropriate recall scans if needed. Some patients can self-refer into this program, and if they do, what they will do is they'll basically do that first step. They will be contacted by a navigator, will do an initial intake, determine if they're eligible for a low-dose CT, and if they are eligible, they will contact the primary care provider to ask if they think a referral is appropriate. Next slide, please. So what does the referring practitioner and primary care provider get back? Well, they get back a report. The report will give them the screening results. And if there are next steps, to let them know what they are, and they will automatically be referred on to those next steps if they're related to the screening, i.e. They look suspicious for lung cancer. Incidental findings, though, are the responsibility of the referring physician to manage. They are indicated separately but clearly on the report. And if we go to the next slide, I'll talk a little bit more about incidental findings, because I think this is an important point on this screening program. So the incidental findings, like I said, they're on the initial report. They will also, if there are actionable incidental findings, then they will be sending a second communication later as a reminder to both the referring practitioner and the primary care practitioner. Now, practically speaking, that's usually the same person, but if they're different, they'll both get communications reminding them to follow up on the incidental finding. Next slide, please. So this is just the referral letter, and it's a pretty standard referral letter, asking some pretty basic information to get the process started. I'm sure people may have questions regarding. If there's nothing right now in this, then I'll happily address them at the end. I'm going to pass the baton on now to Dr. Shaheen, who is going to be talking about breast cancer screening. Dr. Shaheen?
Thank you so much. Okay, great. I'm the regional cancer and breast imaging lead for the region, and the objectives of my talk are the following. I thought I would focus on a certain area because, as you know, breast cancer screening is huge and we cannot address that in 10 minutes. But there is a topic that's now a hot topic in the media, which is breast density, as there are many challenges. So we're going to highlight some of the challenges for this breast density and the impact on workflow and breast imaging. And I'm going to present some cases on some emerging technologies that we have utilized in our region to address it, and discuss the role of primary care physicians in addressing breast density. Next slide, please. As we all know, the Ontario Breast Screening Program has two arms, the average risk and the high risk. The average risk would include women from 50 to 74, and that would offer the 2D digital screening mammograms, while the high risk screening program, it's for women from 30 to 69, and it will offer both the screening mammograms and the MRI on annual basis. Next slide, please. So women outside this screen eligible population, they will have to discuss the options for their breast cancer screening with their referring physician so that they can get a mammogram or any alternative other modality. Next slide, please. So goals of screening, just to remind you, is to have equitable early detection of breast cancer when it's small and node negative, and to reduce the interval cancers and to reduce mortality and morbidity. So there is a need for more effective screening strategy, likely more frequently screening, supplemental screening with other modalities, develop personalized screening programs, and risk assessment. So a risk-based approach is expected to improve the benefit-harm ratio of breast cancer screening programs. Next, please. So what is breast density? Breast density is basically the amount of fibroglandular tissue in relation to the fatty tissue in the breast. So the radio opaque, which is like more of the whitish tissue that you can see in the left breast, this is called high density breast tissue, as opposed to the fatty tissue, which is like radiolucent. It's like fatty breast, and you can see the cancer easier, as you can see here in the marked small cancer in the fatty breast. Next, please. So this breast density varies greatly throughout the woman's life, and it depends on multiple factors, whether they are indigenous or exogenous factors. So that's why it's not just different between women, but also within the different age stages of the women. Next, please. So why breast density? Because it turned out that the high breast density is one of the strongest independent and most prevalent risk factors for breast cancer in both premenopausal and postmenopausal women, and had the largest effect on the population attributable risk proportion for the breast cancer. Next, please. So women with breast with dense breasts, they can have, actually studies have shown that they will have reduced performance of screening mammography because it's going to hide the cancer. And this is reflected also in the high interval cancer rates, which means cancer detected in the interval between the planned screening visits, meaning that if the woman is having a negative mammogram, she can, before she's due for the next screening, she will feel something and she would come and there would be a cancer. Also, there is reduced both cancer detection rate and reduction in breast cancer mortality. Next, please. So more advanced breast cancers are noted in dense breasts compared to the non-dense breasts, with a percentage of 41 in non-dense breast and 13% in dense breast in terms of the mortality reduction. Next, please. So the incidence of interval cancer in provinces where mammography is performed every 2 years was compared to provinces that recall women with dense breasts annually. And they noted that, and that's in a study done by Dr. Seeley, that significantly fewer interval cancers in provinces where annual mammography is done for women with dense breasts. Next, please. So it's very important to benefit from this study, where basically it's the first to demonstrate that a reduced cancer rate would be, based on annual screening, is going to be helpful for women with dense breasts. Next, please. So dense breast impact and challenges. So women with extremely dense breasts have at least 4 to 5-fold greater risk for developing breast cancer compared to women with fatty breasts due to the masking effect, the independent risk factor for developing breast cancer, and the higher rate of local regional recurrence if they had previous history of breast cancer, in addition to the false negative and false positive findings. Next, please. So density reporting is variable in Canada. As you know, probably in Ontario, and you have seen that in the screening report that you've got recently, we have the stratified breast density types of breast densities, the 4 categories all the way from fatty to extremely dense breast. However, the Ontario breast screening program have always stratified it into the binary system, which is greater than 75% or less. Next. So the program does not recommend, our program in OBSB, does not recommend supplemental screening beyond screening mammography for women with dense breast, as the benefit of supplemental screening is unknown. And this has created a lot of debatable and confusion actually among women in the public, because now they are entitled to know what's their breast density, and they always ask, what does it mean? And how come now that I have a higher risk, I don't entitled to get ultrasound or MRI? Next, please. So as you know, since we cannot offer MRI or we cannot offer ultrasound for screening for many good reasons that I don't have the time to go through that, we thought that there are alternative pathways. In addition to tomosynthesis that's been utilized at many facilities, especially for the heterogeneously dense breast, now we can offer contrast-enhanced mammography, which has been offered in other areas, in other regions outside the eastern region, where basically you can see here the breast is extremely dense, but when we injected IV contrast and got the subtracted images, it's really a quiet breast. And this gives us the confidence that this is actually a negative, there are no enhancing lesions, almost like an MRI. Next, please. So in terms of comparing contrast enhanced mammography and MRI, it's actually very comparable when it comes to screening, except that we are missing a little bit of the posterior tissue and the axilla. We can't see them. That's the benefit of the MRI. However, it's a great initial step, and it's very comparable and accessible to many centers because everybody would have the contrast and the access to mammography, as opposed not everyone, especially at global level, have access to MRI. Next, please. So this is an example for a case where a patient got worked up with contrast enhanced mammography for architectural distortion in the left breast. Next. And as you can see here, the left breast actually is very quiet on the subtraction images, but there is an incidental finding on the right breast where this was an enhancing mass. Patient was taken to ultrasound and found to be cancer. Next, please. This is a patient with architectural distortion and had targeted ultrasound for the right breast. However, we really couldn't see much. And the patient, next, please. And the patient came back after 6 months. Next slide, please. And as you can see here, yes, the architectural distortion got more pronounced. And on contrast enhanced mammography, you can see the area of enhancement. We're wondering if contrast enhanced mammography was offered earlier, like 6 months ago, would that have been shown earlier than waiting for 6 months? And when we took the patient for ultrasound, actually it turned out to be cancer. Next, please. So here's the cancer with the hypoechoic area with posterior acoustic shadowing, classic for cancer. Next, please. So what's the role of primary care physicians in addressing breast density? First of all, you need to be aware that patients are going to discuss that with you, even if even if it's not just in the report, they're going to hear about it in the media, and they feel that they need to get the access to screening. So yes, we need to follow our guidelines. However, there are different modalities that I've talked about, and I'm happy to discuss them more. And there is on the website of Ontario Breast Screening Program some information that would help patients and primary care physicians to discuss, have a better, more understanding for the issue and the limitations, and why we need more time to get more evidence to offer more supplemental screening. And I look forward to your questions in the question and answer session. Thank you so much.
Hi, my name's Hugh Kendall. I'm the regional lead for colorectal screening. I'm a general surgeon in Ajax. I'll try to do this presentation fairly straightforward, not trying to go over, I dislike reading slides. So what I'd like to do is to quickly get to the point where I can give you some take-home messages that are fairly succinct and leave time for questions at the end of the presentation. Colon cancer, obviously, very relevant to everybody's practice in general. If you have a 2,000 person practice and you followed them all from birth to death, you can expect about 130 of your patients to ultimately get colon cancer during that time. And the survival rates for stage 1, a 92% 5-year survival, all the way to stage 4, 15% 5-year survival. So you've got a lot of patients who have a fair amount riding on colorectal cancer screening. One of the big advances in the last few years has obviously been the FIT test. There are several advantages when I talk about it to patients. One that they know about is they dislike the old guaiac test because it was 3 separate specimens within a 10-day period. I sell it to them now as it looks like a little computer USB key. You click it open, you stab it in a piece of stool, you click it shut, and you drop it in the mail. It's the people for whom this is appropriate is really kind of what I want to go into in some detail. There are perhaps some surprising bits about who should and who shouldn't be getting FIT testing. Essentially, anyone who is average risk, 50 to 74 years old, should be getting FIT testing every 2 years, starting at age 50. Anybody who needs screening before age 50 doesn't need FIT testing. They are by definition increased risk. There is no FIT testing prior to 50. And prior to about 2 years ago, there was no FIT testing after 75. In the last couple of years, FIT tests have been released for patients between 75 and 80 years old. It's a bit of a gray area, and I'm happy to answer some questions about that later. The patients who are increased risk get colonoscopy. The definition of increased risk is perhaps not intuitive. And it's one that is subject to change. Currently, increased risk includes anybody with a first-degree relative. Older versions of the guidelines used to include 2 second-degree relatives as an equivalent for a first-degree relative, like an uncle and a grandparent, or an uncle and an aunt. That equals a family history. Under the current guidelines, that does not equal a family history. They would still do FIT testing. So let's go to the next slide. This is going to be a logistical issue. You all are familiar with the FIT requisition, I'm sure, particularly if you have an EMR. There are issues related to the FIT program that mesh with your EMRs and mesh really with the frequency of visits that are happening in family practice. So we have seen the number of FIT rejections over the last 18 months, the number of requisitions that are rejected based on OHIP eligibility is shockingly large. I think it's many thousands per month. And that's not because tests are being requested on people who don't have OHIP coverage. It's because tests are being requested on patients who don't have an up-to-date OHIP number with a valid version code. So it's very important to always check your patient's up-to-date version code and address, because as you may or may not know, the kits go out with that patient's name, barcode, name, healthcare number, birth date. It's unique, it's barcoded for them. The reason this system exists is that the FIT test is a much more expensive test than the old GUAIAC test. The old GUAIAC test was about 30 cents per unit, and it would last for years. So it's something that you literally could have behind your own desk, behind a desk of a pharmacy. The new kit is hundreds of times more expensive. I think it's somewhere in the region of $6 or $7 per kit, but it also has a short half-life. The chemical reagents within the kit will degrade, particularly once it's opened. And it is, to a certain extent, heat and cold intolerant. So, you know, when your patients are mailing it back when it's -30 out, or when it's going to sit in a long weekend in the middle of the summer in a mailbox that might reach like 50 degrees Celsius, these are all issues that were problems. So there is no repository of tests behind your desks or in the pharmacy or my desk. It's you send it out, we'll send one to them. But it does mean that in the age of EMRs, where we're capable of doing a query and sending off a mass mailing, that it does create issues of redundancy and rejected requisitions. So it's something, next slide, please. It's something, oh, I thought there was a second slide. Can you go back to? Is there another one with that same kit? Anyway, no, go for it. That's the one. So that little box, I'm sure you all know about it, but when you get a patient, when you're notified that a FIT kit has not been returned, or if you talk to the patient for another reason and they say, yeah, I don't even know where that thing is, I lost it, it is important to check that box because that will tell Life Labs, forget about waiting for that kit that you sent out. If you don't check that box, your second request will be rejected because there's an open file and they're waiting for that first test kit. So these are just simple logistical things. You know, make sure if you're requesting a kit when there's a live kit out there, make sure you check that box. Try not to do sort of blind queries and mass mailings because you're going to get a lot of rejections. And please make sure that your OHIP numbers and addresses are up to date, and that is going to greatly reduce the number of rejected requests. So go to the next slide. This is the slide that I really kind of wanted to spend most of the talk on. And this is stuff that may surprise people a little bit. And these are all sort of myths and misconceptions about FIT and colonoscopy. The first one is that colonoscopy, you know, is better than FIT testing. FIT testing is okay, it's cheaper, you know, totally fair for the government to prefer one over the other on the basis of cost. But when you know, push comes to shove, colonoscopy is just a better test than FIT testing. And for the high-risk people, it is. But for average risk people, it is absolutely 100% identical. So FIT testing every 2 years versus colonoscopy every 10 years, they are absolutely identical in their ability to keep your patients not dead of colon cancer. So you have to define the outcome, which is 10-year colon cancer mortality. There's a very good study on which CCO at the time based a lot of their logic, and it's Quintero, Quintero. It's from 2012. It's about 25 or 26,000 patients in each arm. Patients were allowed to choose. They were randomized, and then they got to cross over. You know, if somebody wanted to do colonoscopy who got FIT, or vice versa, they got to change. The end result was that FIT was a more popular option, meaning more people switched from colonoscopy to FIT than FIT to colonoscopy. And ultimately, the 10-year mortality for colon cancer was absolutely the same in both the FIT and the colonoscopy groups. Colonoscopy was more effective at detecting advanced adenomas, but the number of people who die of advanced adenomas is 0.0%. They only die of colon cancer. And so your end result, your end metric of colon cancer deaths is really the thing that should carry the day, and they are completely equal. The second kind of misconception is that, okay, if FIT is still effective, it's fiscally responsible, it's effective clinically, but still, just to sort of see whether there's something weird going on, everybody should have a baseline colonoscopy at some time in their life. That isn't the case. You know, the definitions of average and increased risk are pretty well honed. And I'll say they're also a moving target. They're not they were not something that was chosen 10 years ago and remain immutable. The definition of increased risk is currently under review at Ontario Health. And it may be that increased risk in the future is only going to be defined as having a first-degree relative who had colon cancer under 60. It may be that, you know, having a dad who had it at 88 or a brother who had it at 74, it's possible that in future, even that won't be defined as elevated risk for colorectal cancer. The third point, that second-degree relatives can, in some number or combination, ultimately equal having a first-degree relative. That's not the current definition of elevated risk. So all those patients who have uncles, aunts, and even the ones that sound more significant, such as, well, I have a close friend and cousin who had colon cancer at 38, so, you know, I should have a colonoscopy. Technically speaking, they shouldn't. They share 12.5% of that person's DNA. And so if there were really, you know, genetics going on that were active in them, there probably would be people between them and their cousin who had colorectal cancer. This is perhaps excuse me for a second, my dog. This last one is probably the one that will be surprising. Excuse me for a second. I apologize. The thing that's most surprising for people is that once a colonoscopy has been performed, the patient is clear for 10 years. Many people will think that FIT testing should resume. And I think it's because intuitively people think of colonoscopy as a backward-looking test. You have a colonoscopy, it was clear. The thinking is, okay, no cancer is developed in the last 10 years. But in reality, it is as much a forward-looking test. If someone has been able to look up and down the entire colon, and there's not even a 3-millimeter polyp there, it should be harder for that person to die of colon cancer in the next 10 years, because you know that they're starting from sort of absolute zero. And we know that the things that grow in the colon grow very slowly. You know, any endoscopist in the province who does a colonoscopy that is sort of termed normal, if that patient shows up with a colon cancer anywhere in Canada in the next 3 years, that shows up as a quality dot on that endoscopist profile. The assumption being that if someone went from a normal colonoscopy to colon cancer inside of 3 years, they probably, or they might have had something missing at that first colonoscopy. So we know that the things that grow in the colon grow very, very slowly. And so when you do a colonoscopy and there's nothing there, it's a forward-looking test and no screening is due for 10 years. Next slide. So the technical points in terms of FIT kit, this sort of wrapping up here. FIT kits, obviously, you don't need for symptomatic patients. They need colonoscopies. First-degree relatives are increased risk. They shouldn't have FIT kits. They should have a colonoscopy. Patients who have had a colonoscopy in the last 10 years, as I was just saying, they're up to date until 10 years after their colonoscopy. And this last, asymptomatic patients who have a colonoscopy upcoming within 5 years, i.e., so the only people that would have a planned colonoscopy within the next 5 years are either people already enrolled in a colonoscopy program as they are definition of high risk, or B, they've had a polyp say they had a polyp in 2018 and they have a planned colonoscopy up in 2023. Those people also don't need a FIT test. And next, so this is what I tried to get to. I think I probably made it a little more complex and maybe a little more difficult to take home these messages, but these are the messages to take home. FIT testing starts at 50. Anybody who needs it earlier shouldn't be having FIT testing. They should be having colonoscopy. Don't do symptomatic people with a family history and first-degree relatives, or people who are already in any kind of follow-up for polyps. After a normal FIT, you don't need a colonoscopy, or after a normal colonoscopy, sorry, you don't need a FIT test for 10 years. And this is the last one that I may get some questions about. FIT testing had been ending at 75. And after that, the paradigm is, if there are clinical problems worthy of investigation, they will be investigated as they arise with colonoscopy. There's no longer a role for FIT. Screening between 75 and 80 is a gray area. Obviously, the first thing to think about would be people who are extraordinarily healthy and are at real risk from a disease which has a chance of taking their life within the next 5 or 6 years, which is colon cancer. The other area is as a follow-up to polyps. There is a guideline from Ontario Health that the follow-up of single small polyps can now be accomplished with a FIT test rather than a colonoscopy. And so we all sometimes see a patient who had a polyp at 74, and are you going to do a follow-up or are you not going to do a follow-up? And the answer to that now might be to do a FIT test in 3 or 5 years rather than a colonoscopy. And that obviously goes against what I put there in number 2. So that's kind of a lot of information. I don't think I succeeded in making it simple, but I'll stop there and happy to answer questions at the end.
Hi there. Nathan Roth. I'm the regional lead for cervical screening. And next slide. What we're going to do is we're going to provide an update on changes in screening, a vision for cervical screening, review some data and metrics, and at the end of our discussion, have an open dialogue towards a framework for improvement. Next slide, please. I want you to remember 2 things from this presentation. Number 1 is all your female patients should be screened for cervical cancer. Up to 20% of the population is not screened, and every physician is accountable to provide cervical screening to every patient. The other thing I want you to remember is everybody should be offered HPV immunization. Why? Because cervical cancer can be eradicated if everybody is immunized appropriately with HPV vaccine. This goes through, so those are the 2 take-home messages that I want you to go home with. Currently, the recommendation is starting to do screening at the age of 21. It's going to be moved to 25. That's in preparation for HPV testing. Every patient of yours should have HPV testing when it becomes available, according to the guidelines, and therefore, after a negative HPV test, they will not need another screening test for another 3 years. Why? Because the sensitivity and specificity of HPV testing is so high that it actually eliminates the opportunity of those individuals to have cervical cancer. Next slide, please. A couple little nuances along the way. If a pap smear shows atrophy, you don't need to repeat the pap. If it shows endometrial cells, if endometrial cells aren't expected in somebody who's menopausal, you should do an endometrial biopsy. And the transformation zone isn't going to be as relevant when we do HPV testing, because high-risk HPV testing will tell you that the patient is at high risk of getting having an abnormal lesion on their cervix and need a colposcopy. Next slide, please. So what we want to do is in cervical screening, provide a framework, knowing that we're all accountable for actually improving the cervical screening rate in our patients. And that doesn't only lead to hospital leadership, it leads to the managers, really leadership in your institution, physicians. And our mission as actually leaders of the screening programs is to give you insight and to tell you what we have to do as providers to increase the rates of screening. Because as you remember in medical school, and one of the first lectures that I learned in medical school was there's three things that increase longevity, our lifelong longevity. Number one, the use of antibiotics. Number two was immunization. And number three was screening. So let's look at the future. The future is, if we don't own these three domains as healthcare providers and physicians, somebody else will take them away. And first of all, I want to thank you all for working so hard during the COVID epidemic. But at the same time, look who took charge of immunization. It was actually the pharmacists. They worked around the physicians. Who's going to be able to prescribe antibiotics in the future? The pharmacists. So our domain that we have to own is screening. Next slide, please. So we need your input, the input of the client or the patient. We need a collaborative framework that's knowledgeable. We need our goal, and we have to build sustainability in the process to make sure that we achieve the best rates of screening possible for our patients. Next slide, please. So again, our customers are our patients, and we're the frontline workers. Middle management is there to support us, top management to support us, but all in support of our patients. And we have to have an agile enough system, and we provide that agile system to allow screening for each and every patient that comes through our doors. Next slide, please. Now, we want to simplify the process. And through the screening program, the regional screening program, we want to understand that I did an analysis of wait times. Wait times from having an abnormal PAP, a high-risk abnormal PAP, that's a high-grade intraepithelial lesion, to actually get to colposcopy. And that usually takes on an average of 56 days. That patient should actually be able to go to colposcopy right away. They should actually have access to the system by a direct appointment for colposcopy. It's our goal to aim for that to happen. The bottlenecks and the actual pinch points in the system are actually waiting for referrals. It's our goal in the cervical screening program to allow access to colposcopists with high-grade, when you have high-grade lesions, to allow the colposcopist to see that patient within 2 weeks. Do you know that in our region, to get a colposcopy at the 90th percentile, those are the individuals who get the colposcopy, some people have to wait 120 days. 120 days to get colposcopy for a high-grade lesion in our region. That's unacceptable. And next slide, please. So as providers, unfortunately, we're on the left side. We're on the left side, and what we're trying to do is we're trying to move to the right side of this cost quality curve, because we recognize that the prevention costs actually are much less than the failure costs, because the prevention costs are not only measured in monetary values, but also in family values, relationships between kids and parents, and really the opportunity of us to provide screening to really all our patients. Because if we do, we actually have a lower total cost, and actually meeting one of the three pillars that I learned when I started medical school. Next slide, please. So what our data shows, the wait time to tests. As I said, the average is about 52, and the upper 90th percent could be 120 days. Next slide, please. So we did a SWOT analysis, and we recognized that we have a couple issues. We have dedicated professionals, which are the providers and the managers, et cetera. We have excellent data. We have data at the provincial, local levels. We have opportunities for improvement. We have opportunities to improve patient satisfaction and decrease the risk of cancer because we actually do screening. Our weakness is we don't have, at least from a specialist perspective, funding to rejig the whole program to make it customer focused, but we're going to do it within the current system. And what we have to do is we have to change the culture to allow access to the primary care providers, to specialists in a timely fashion, to allow our patients to actually get timely service. Next slide, please. And this is actually the model of quality service. And sometimes it's scary for all of us when I get an email to say that it takes 60 days for somebody to review my patient's PAP. That's unacceptable. It's unacceptable. It's unacceptable to our providers, and it's unacceptable to our patients. And we have to be advocates to change that. Now, there's some individuals who say, well, you know what? There's no way. I'm not going to change. I'm going to keep the system the same way it is. You're going to wait for my colposcopy clinic for 2 months. That isn't going to fly because somebody else is going to take up that role unless we actually are agile enough to get a system that actually allows the patient to be at the center of that system. So I think that the opportunity is for us as individuals who are frontline workers who care about our patients to change the system. Next slide. This is the number of high-grade patients with an abnormal PAP who have actually no follow-up. That number is 17%. So a patient with a high-grade lesion of their cervix, they're lost to follow-up. It's in the hands of the primary care specialist. It's in the hands of the patient who may have moved out of the country. It's in the hands of our cervical screening program that could send a letter if you have a low-risk lesion, or maybe send a letter to the wrong address. But it's in all of our hands to develop a system that allows these patients to get access with one simple call from the primary care provider to the specialist. Next slide, please. So what do we have to do? We're all responsible. We're all accountable. We're supportive of each other with a combined vision. We're all informed and we know what we have to do. Next slide. So what do we have to do? So right now, this curve on the left side tells us that we're actually not meeting the benchmarks, not the benchmarks of Cancer Care Ontario. And believe it or not, we're only looking for the 50th percentile to improve. But really, I just told you that there's people waiting 120 days to be seen. If we actually move that system to the left, it's not achievable. I did some data and analytics on it. We have to change the system. So we have to allow family doctors to have direct access to colposcopists who can actually do the procedures in a timely way. So that's how we center the process. We're going to center the process so patients get treated in a timely fashion. So let's go back to the beginning. I'm asking you to do two things: to actually screen every patient for cervical cancer, to do HPV when it's available. And what I want you to do is to have every patient immunized against HPV. I personally know two male physician friends of mine who have laryngeal cancer. And they've been treated with radiation because of HPV. You all in the room know individuals who have HPV-related illnesses. This can be eradicated with your help, and it's our responsibility to make it a more efficient process. And I look forward to your questions.
Great. Thanks very much, everyone. I appreciate that. Really strong finish there by Dr. Roth. We just jumped right into the presentation. So for those of you who don't have a chance, I'm Dr. Pasenko, and Dr. Termesi and I are the two moderators for this event. We've got a couple questions here from attendees, and so I'll send them directly to the representative speakers. So the first one of these is going to go to Dr. Kendall, and it's a question about people who live in smaller centers where a general surgeon performs colonoscopy less often than larger centers. Would older people there be better served to travel to a regional center with an endoscopist to improve quality outcomes, including ruptures and infection?
If I'm reading and hearing right, the question really is there a problem with endoscopy quality when you have a low volume provider? And the answer, to be fair, is in the past, maybe. What many people may not know is that for the last 6 years now, every endoscopist in the province, OHP or hospital-based, has a report card, and it gives them the exact number that they use OHIP billing data, and billing data also includes whether polyps are taken out, whether biopsies are done, and because they're able to match the OHIP billing data that Dr. X did with any OHIP billing data that somebody else did to treat a perforation or a bleed and everything, you can actually get all this data. So everybody gets a report card. They get it every year. It goes over about 20 different metrics. Everybody in the province needs to do at least 200 colonoscopies a year to be sort of on side of this. They have their perforation, their bleeding rate looked at. They looked at what's called missed colon cancers, which I touched on, anyone who's diagnosed with a cancer within 3 years. So every physician gets that report card, and every regional lead, like myself, is tasked with reviewing that quality data from their region, and if there are quality outliers, they're highlighted, and they get a very structured process like a R2C2 feedback session, and reports are written. So the answer in 2022 is I would have anybody who's doing endoscopy in 2022 is meeting a quality standard, full stop.
Great, that's incredibly reassuring. Thank you. Our next question, I think I'll turn back to Dr. Roth. The question is, do we think that we're going to be moving towards self-sampling for pap smears at some point in the immediate future, kind of similar to what's being done with FIT testing? What are your thoughts? You're on mute.
The literature actually says there's actually no difference between self-testing and physician testing for HPV. But it's taken us 20 years to get HPV, and it'll be approved over the next year or two in the province. So I agree. I think totally the patients will be better off if they're able to be self-tested, but I also think the physicians have an important role in it. That's why we have to embrace HPV testing to the fullest. Otherwise, we may be left out of that.
And I see a hand up from Dr. Termesi.
Yeah, thanks, Mark. So just a couple of clarifications. So first of all, thanks for this excellent session, but I did want to actually just coming back to something that Dr. Roth mentioned, and this is sort of I guess it's a statement, not so much a question, but one of the things that I do want everyone to be mindful about is over the last couple of years, the role that primary care has really played in terms of vaccines, prevention, and the overall sort of care of the COVID patients. But I think the discussion here is a lot of times pharmacists are stepping up because they are a stronger lobby group than primary care providers. In many ways, there really is a financial reason that the whole concept of vaccines and antibiotics would be of interest to them versus prevention, which from a primary care provider takes a lot more education and time and engagement with our patients. So I just did want to highlight that. And going future, I mean, I think this is where our panel of experts, as well as primary care providers, should really focus on the fact that, to be honest, like this was episodic with what happened in the pandemic, but I think we should focus on the importance of pediatricians and primary care providers for vaccines, the education and everything that went along with it. So I just wanted to put that out there because I do think that, and this is just a 30-second tidbit I'll share. I was overseas for a healthcare conference in Egypt last week. One of the key things that they're doing wrong there that they've highlighted on a national level is the misuse of vaccine and antibiotics without the regulation and accountability of the local small pharmacies and pharmacists, because the education to patients is not there and then the follow-up's not there. So I think that we all have to be mindful, as much as prevention is super important as primary care role, but so are the other two buckets. So I did want to just highlight that. The second thing, and this is a question related just to all the panelists, with overall cancer prevention and screening, have you guys noticed in terms of the data for 2021 and 20, is there a significant decrease in terms of screening? Can one or maybe all of you quickly comment on that?
The colon cancer check program has been probably the most fortunate of the screening programs because we are so based in terms of mailing stuff out to the patients. So that's been a huge advantage. And right now we are back. Now, when the pandemic hit, we were ramping up because from a start in 2019, but we are past 2019 in terms of FIT positive colonoscopies done, requests for FIT tests, and FIT tests being mailed out. So we're ahead of where we were in front of the pandemic.
Great.
But
And
not for breast, basically, as you know, we had some shutdowns. So we saw some decrease in, the mixed messages about coming to the hospitals and the screening centers, but now we're going back to pre-COVID levels, and we're even backed up with wait times longer than usual for getting screening. So actually we're back to normal in terms of pre-COVID volumes in breast screening.
And cervical screening is reaching the level of pre-pandemic proportions. So it is reaching the same level.
The low dose CT scanning for lung cancer was on hold for part of the time period. So they were a little behind even on getting some of the catch-ups done, but they are getting caught up now. I think across the province though, cancer screening did decrease during those 2 years. I think that's pretty well documented, and I can send you that data if you're interested. Our region is no different than other regions. We're pretty consistent in terms of the drop in screening for various reasons.
yeah, if you could send it, it's just nice to share with some of the groups like primary care providers that are not doing as many in-person visits yet, just to give a little bit more of a push.
Absolutely.
Well, perfect. Thanks, everyone. It looks like we're just at 8 o'clock, so we did this for exactly in the 1 hour. Thanks to everyone who attended, and thanks again very much to our panelists, who I think gave us a very important practice update, especially as we're starting to reopen our practices and get back to kind of routine and expected screening for our patients. I think this is a very key reminder of the importance of screening, and certainly as one of the key improvements in mortality in the 20th and 21st century, and some of the things for us to be mindful of as primary care providers going forward. Thanks again, everyone, and we'll see all of you as either attendees or panelists in the immediate future.
Thanks for having us. Okay,
Thanks.
good to see you. Okay,
Thanks, everybody.
Yeah, bye.